The types and causes of cancer, we covered the diagnosis, the treatment. Now let's talk about cost. And let me bring in Lucy Njeri on this. Lucy, how much did it cost you to deal with cancer this far?
I must say that I'm one of the luckiest people during my cancer treatment. NHIF was covering everything.
Okay.
Back then, 2017. The only contribution I was doing was 500. So I went into Kenyatta. I had total mastectomy. I didn't pay a cent. I did radiotherapy. I only did a top-up of 2,000.
Okay.
And chemotherapy, it paid for me everything. The only out-of-pocket expenses that I had by then were for imaging, mammography. It was not covered by then, and CT scan.
Okay.
And at some point, I went to, I think, German Center. That time, they were covering partially, and I did it. So I'm one of the luckiest people by then, and there was no top-up for NHIF, who was very lucky. And as I said, my mother at that time was also suffering from throat cancer, and she received her treatment at Texas, and we didn't pay anything. She did 16 cycles of chemo and radiotherapy every day for 4 months. We paid 0 balance. Okay. That was net. But now it's different. Before you look at the treatment, I have one question, diagnostic. What is the need of paying hundreds and hundreds of money for treatment, and you can't pay for a biopsy or immunohistochemistry for a patient? I'm caught in stage 1. Before I go back home and look for 13,000 to come and do my biopsy, to look for another, 20,000 to do immunohistochemistry, it will take me so long. And then by the time I'm coming back to see the oncologist, it is in level 3 or level 4. So my question is, why don't we cover the diagnostic right from the start so that the patient can get access to treatment timely? Okay. Because there's a lot of time wastage in between.
Okay. Yes.
And this issue of topping up. Right now, nobody has money under the bed that you're told that you have to top up for 2 years or 3 years. And then in the midst of it, you're told that it is exhausted. And majority of us, sisi ni wananchi, sisi ni Wanjiko, uchumi kidogo. So there's a Harambee here, there's a WhatsApp group here and there. And then you're told all of a sudden that even after topping up for 2 years, it is not valid. And it has exhausted. So it leaves our people. Right now, there was a conversation this morning. Who did treatment, who did chemo, and mastectomy. But she could not raise money for radiotherapy. She's in the house 4 months later. Then what do we do with that patient, or where do we start with that patient?
Na bila shaka naona pia vile Samuel Mburu alikuwa anatikisha kichwa, atakochukua kipaza sauti tuzungumze kwa dakika moja. Gharama ikoje? Kwa sababu naona kwa wanapozungumza ni kama wanakubaliana na je, familia ilipitia wakati mgumu, labda mlitumia pesa kiasi gani kuhakikisha kwamba mnashughulikia yule ambaye alikuwa na saratani katika familia?
Thank you, Rashid, and thank you, Trevor, and thanks for this timely conversation. I'm sure by now kuna maisha ya mtu imebadilika for now, because amejua kuna cancer and the process of treatment. I would like to bring to the attention to the entire nation, even to the diaspora, that we are all candidates of cancer. We are all candidates of cancer. But now the management and the treatment is on a different angle. Personally, I've been affected 85%. Because from the relative perspective, from the Fred's perspective, and also from the sector that I represent. I'm the Secretary General of the informal sector in Kenya. So, and then this is the economic pillar, of which you see this journey of cancer treatment and management, it needs finances. So now it comes now the economic. Ikiingia hii mambo ya pesa, hasa yule anasubuka saidi is a hustler, of which we appreciate the good heart of the president, mwenye anasemanga hustler, hustler, hustler. But now sasa ikija mambo zingine, hustler anasubuka. In our social setups, especially in the economic sector, mostly we have the members who do in different activities. Wakati hii jaga ya cancer imeingia kwake, it means hata kufanya kazi kwake ni ngumu. Pia sisi wale tunawashikilia inakuwa ngumu, because most of the times we are spending in hospital and out hospital. What will happen? From the nutritionist level, the dieting system yenye ameandikiwa itakuwa ngumu. Akikosa kukula ile chakula ameandikiwa na daktari, what will happen? Even if the treatment iko sawa, and a certain gap is missing, the entire treatment itakuwa null and void. Tugie pade ya NHIF. We have made it mandatory to all our associations that I represent, is compulsory kila mtu akuwe na NHIF. But now wakati anaenda kuitumia hospitali, especially now to the discussion today ya watu ya cancer, unaambiwa you do an extra top up. Yeah. The extra top up you are doing sio mwaka moja ama miaka miwili. Currently I have a patient at KU. Amekuwa akienda huko and juzi bado alienda huko. Akaambiwa do an extra top up of 2 years, which is 12K. The same NHIF card ameitumia from the point of referral, which is Murang'a. Then akija KU anaambiwa top up. Kama huyu member yetu angekuwa na pesa, why should he move all the way, all those intercounties, to come and look for the services at KU?
Okay, let me bring in Pius on this and also hear the story of expenses. Pius, wewe umetumia pesa ngapi kumgharamia matibabu ya mkeo?
It has been very expensive on my side. Okay. By then sikuwa na NHIF wakati mgonjwa wangu alianza. Nikakata. Lakini wakati naenda Kenyatta, naambiwa dawa haiko. Enda ununua dawa nje. Ukienda kununua dawa nje, ukirudi Kenyatta, unaambiwa dawa ununua 17,500. Ukirudi Kenyatta, unaambiwa lipa 5,000 ya kuchanganya dawa. Hiyo pesa hona. In fact, watu wa kanza wameenda kwa shida kubwa. Angalia kwa mama, labda watu wengine mabwana wametoroka, wengine kitambukansi ipone, umeuza kila kitu kwa nyumba, maisha inakuwa ngumu. Mimi ningeomba serikali yetu, hii pesa ambayo wanapatiana watu wazee, at least watu wa kanza victims wangekuwa napewa hii pesa. Juu survival imekuwa so hard. Umeuza kila kitu, watoto wanafaa wasome, kukula ni shida, nutrition vile my brother amesema ni shida, vile utanunua chakula.
Daktari kidogo Jacqueline, kama utaweza kuzungumza, mpitishie kipaza sauti. Hizi ni hali ambazo mnakutana nazo kila siku. Na ukiangalia wanazungumza kwamba wanapatikana magonjwa ambayo wengine hata hawakujua wako nayo. Hali ya maisha ni ngumu na wanalazimika kuuza vitu vyao kupambana na ugonjwa kama huo. Lako ni lipi kuhusiana na gharama ya kupambana na saratani?
Thank you for the question. I think what's coming out from multiple discussions is that this is a multifactorial issue. There is the healthcare system itself, where there needs to be facilitation at multiple levels, from facilitation of the healthcare that's available, facilitation of the treatment that's available. This is done through our taxes. I think that most of us pay. There also needs to be facilitation economically, because what's happening in the country as well economically affects what you're able to do. Like the cancer warriors here and the families of the cancer warriors here are saying, if food is unaffordable, you're unable to actually have good response with your treatment. If you are unable to go to work, there's someone who is talking about not being able to find work even after being well and even being in remission. So, I mean, it's good that we're having these conversations. I think it's very complex. I think it's multifactorial. But my thought would be that there needs to be more facilitation, and it needs to be a national level facilitation at multiple levels with experts, as we are having here at the moment, contributing to that that solution.
You're a radiologist, Dr. Mavuti. How much does it cost on average?
It's very expensive.
How much is expensive?
No, it really depends on what you need. There are multiple types of imaging types that you can do. An ultrasound, depending on where you get it from, can cost for as little as 1,500 shillings, but it can be as much as 8,000 shillings. The PET-CT that we're seeing, it's available in 2 centers, one a government facility and one a private facility where I work at, is anywhere from 50,000 shillings to 80,000 shillings. And there are also other tests as well that cost upwards of 200,000 shillings as well. So as someone is mentioning, the diagnostics are so expensive. The biopsies are so expensive. We also do biopsies as radiologists. So again, it's a matter of facilitation because a lot of these services are offered on a private basis, and so there's a cost incurred in trying to offer those services as well.
Na ukizungumza na kokona mwana Cecilia ambaye ako karibu na wewe anatikisa kichwa. Unaposikia gharama, wajua kuna watu wanajua tu kwamba hawa ni mashujaa wa saratani, lakini hawajui mnapitia kitu gani ili kupambana na hiyo saratani mpaka muitwe mashujaa. Hebu ambia taifa saratani.
Asante sana Bwana Rashid. Mimi am a caregiver na nimepitia. Nikisema wakati nilikuwa shule ni simulie kidogo. I saw my late grandmother ambapo alipitia kansa ya titi, akakatwa titi lakini ikaendelea. I saw her dying kwa sababu ya kukosa namna. She was working with the city council. Alikuwa anafanya usafi kule kwa clinic. I would say Jericho dispensary. She had worked there for a very long time. Lakini hata ingawa alikuwa akifanya pale kwa clinic, hawakuweza kumsaidia. Na hata isitoshe, aliuza kila kitu. I remember her. It is still fresh in my mind that naonanga ni kama jana, and I was still young. Nimepitia pia kwa marafiki ambapo pia ninajaribu kuwazungumzia, kuwapatia moyo. Like kama leo vile nimekuja, kuna wengine nimezungumza nao waweze kufika hapa, lakini bado unakuta wako na stigma. They don't want to come up. Me, what I would urge Kenyans, it is good to go for screening. Kwa sababu cancer, it is not a death sentence. Ni kitu ambayo inaweza kuwa na tiba, ambapo ikijulikana mapema inaweza kusaidia wengi. Kwa sababu itasaidia wengi kivipi? Kwa sababu wakati wewe umepatikana uko na kansa, mapema utibiwe, haitaguza familia yako, haitaguza mtoto wako. Alafu lingine niweze kupatia Nana moyo. Anasema wanaenda wanatafuta kazi ambapo hawapatiwi nafasi. Naweza kuambia hawa employers, tomorrow it can be your mom, tomorrow it can be your sister, tomorrow it can be your daughter, or tomorrow it can be you. Kwa sababu kansa ya titi si ya wanawake peke yake, hata wanaume. Kwa hivyo tufikiriane na tuweze kusaidiana. Hawa watu tuwashikilie kwa sababu ni binadamu kama sisi.
Okay. All right, let's cross over back to the government studio where Sam and Christine are standing by to get some answers there on whether these costs can actually be regularized. Sam and Christine?
All right, thank you so much, Trevor and Rashid. And I want to begin with the Cabinet Secretary here because you hear there's a success story of NHIF, what it was able to do, but also complaining that the diagnosis process was not covered, but she was covered for treatments. And she's asking a very significant question. Why cover treatment, but you're not covering the diagnosis? I don't know what government has done on that, but also the bigger strategies to ensure that this is actually affordable.
Thank you, Sam, and thank you to those who have given their views on the other studio. It's true that currently NHIF does not cover screening and some of the diagnostics, and that is one of the reasons why we were reforming, or we have reformed NHIF. The other issue that came out there, you must have had one who gave a testimony that they got to take their NHIF card after they were diagnosed. So we have an issue of adverse selection, that until you're diagnosed to have a chronic illness, that is when now you go and get your insurance. That is our second problem with the NHIF as it is currently. The other issue that they have talked about is the issue of top-up. That is to mean that there is a limit within NHIF that the treatment can be covered. Then they have also talked about some of the procedures that are not covered. That means there's exclusion by NHIF. And those are the reasons why we have reformed, and now we have Social Health Authority. What we have done in Social Health Authority is to ensure that we take care of Kenyans from the beginning of their life to the end. From the time a mother is expectant, that is covered under Social Health Authority until to the time that that person is maturing and, God forbid, death. We have covered in the Social Health Authority. Specifically for cancer, we have ensured that we are covering screening and diagnostics at 100%. We have ensured that all treatment for cancer is covered at 100% because we have a publicly funded primary healthcare system. That is where most of the screening and diagnostic would happen. Then once you kick into the secondary care, we have the social health insurance. And that is where your insurance will be taking care of you without exclusion, without limitation. But the best of Social Health Authority is the third fund, which is the Emergency, Critical and Chronic Illness Fund. And let me tell Kenyans, the beneficiaries of this Social Health Authority, the ones who are going to benefit at most, are people with chronic, critical illness, and emergency care, because we have a fund there, which we have established that in a year, we need about 46 billion in that fund. And out of the 46 billion that we have put in that fund, 42 billion is for cancer care. So we say that now we have put in place a mechanism to ensure that we are taking care of you from the point of screening, diagnostics, treatment, and if you need chronic, a chronic maintenance that you are going to be maintained for a long period of time, including rehabilitation and palliative care. It is being covered under the Social Health Authority. And that is why, Sam, I was telling you the big question that we should be asking ourselves now is how do we raise resources to be able to take care of this? One is through our remittances, where now we are saying we have invited Kenyans to a conversation on how much they should be able to pay under social health insurance. I've told you about my experience yesterday where we were celebrating PEPFAR at 20. And we are saying that we have been able to, out of the 1.4 million Kenyans who are HIV positive, 1.3 million are on treatment. That is about 95%. Where did we get funds for this? We got support from USAID. Where does USAID get money from? It gets money from its taxpayers. That the people who pay taxes in America, from their taxes, is how we are getting aid to take care of our patients. So we should now be maturing as a country and think, how do we take care of ourselves as a country? And therefore, I want to encourage Kenyans that where we are supposed to pay taxes, let us pay taxes, because that is how the government raises revenue to be able to facilitate the programs that it has put in place.
And Waziri, I don't know if you would want to clarify, because there has been a contention. The last time you were here, you spoke about 2.75% contribution with a maximum capping of 5,000 shillings. The president has been speaking about 2.75% without a cap. What is the right position in the regulations you're working on?
We have finalized drafting the regulations, and we were at the stage of inviting Kenyans to come and give us views. From where I start with the information I had at that point in time, I thought a cap of 5,000 would do. But now we have opened the discussion. Let Kenyans come and tell us how much they think we should cap, or if at all we shouldn't even cap.
So there's no position.
It is an open conversation that is ongoing. Until the time that now we have finalize the process, which includes public participation, stakeholder involvement, until we finalize that process and say, now here we have, with gazetted regulations, that is the point which when we'll say, this is what we have put it at, either with a cap or without a cap. Kenyans are going to give us that decision. If we are capping, how much?
Okay.
Yes.
Asante Waziri kwa maelezo hayo. Dr. Naftali Busahara, wewe ni rais wa shirika la Kesho ambalo linahusika na utafiti juu ya saratani. Na kulingana na mazungumzo haya, tangu tulipoanza, jambo ambalo limejitokeza wazi ni kwamba matibabu ya saratani yanakuwa ghali kwa sababu zile dawa na vifaa ambavyo tunatumia tunaagiza kutoka nje. Je, katika hiyo idara ya utafiti inawezekana kwamba tunaweza kufanya utafiti ili tuwe na dawa zetu wenyewe hapa nchini za kutumika katika matibabu ya saratani, na pia tuweze kutengeza vifaa vyetu, tusitegemee vifaa vya kutoka ng'ambo, ili tusaidie katika kupunguza gharama ya matibabu ya saratani?
Asante Christine. Jawabu ni ndio, na tumekuwa tukiongea hii maneno jinsi ya kuhakikisha ya kwamba dawa na vifaa za kutumia katika matibabu, sio tu saratani lakini magonjwa yote, ndio yaweze kutengenezwa hapa nchini. Na tukifanya hivyo tutapunguza bei ya hizi madawa na hizi vifaa ambazo wananchi wetu wanahitaji kutumia. Na sio tu kutumia hapa, bali pia tutaweza kuuza kwa mataifa ya ng'ambo na kupata ile foreign exchange ambayo unajua tunahitaji sana.
Ndio.
Jambo la pili kuhusu utafiti ni kwamba utafiti ni wa maana sana kwa kila kitu ambacho tunafanya. Hata wakati wa prevention lazima kuna njia ambazo unaweka ukisema tukifanya hivi tutazuia kansa. Lazima tukue na utafiti ya kukuonyesha hii mwelekeo unafuata ina matokeo aina gani, kwa sababu kila kitu tunafanya lazima tuiangalie kutoka kwa msingi wa utafiti. Ndiyo. Iwe kuzuia, iwe kuhamasisha, iwe matibabu, kila kitu lazima tuichukue kwa msingi wa utafiti. Asante.
Right, and let's get to the question of because I believe that the reason why it's expensive to manage cancer is because of the cost of investment, but also the cost of maintaining the workforce that we have. This is a split question for you, Dr. Meli, and also Dr. Ocheng there. Talk to us about the professionals you need to properly manage cancer. If I may begin with you, Dr. Ocheng.
Thanks so much. So cancer, as I said before, is a complex disease. And to be able to diagnose cancer, we need so many doctors involved, as opposed to many other diseases. Because cancer comes from within you, and we have to differentiate that whatever you have is not normal you, it is you who has become mad and want to destroy you. So if, for example, you have a lump on your neck, you have something swollen on the neck, you will go to an hospital. Any doctor can see that, but the doctor has to differentiate that it is not a normal thing. He has to differentiate it is abnormal, and if it is abnormal, it is not just a growth. It has to be something suspicious like cancer. So any doctor, and most nurses could do that. The next step would be, if that doctor suspects that it is a cancer, then he sends you to another doctor. So you're moving again another step. That doctor, most of the time, is called a surgeon. So the role of the surgeon will be to take a little meat from there. The surgeon could be a surgical oncologist, specialized, or just a general surgeon, any doctor. Or even general doctors can do that, take a little meat. That meat now goes to the first highly specialized person called a pathologist. So now we are having the third stage of the doctor. That pathologist has to look at it and say it has cancer cells and it's not a normal cell, or it's just not a normal growth. If it is a cancer cell, you go to now the fifth doctor. The fifth doctor would be now that we want to check if it is a cancer cell, as it spread somewhere else. You need now a radiologist. Now this radiologist will do scans and interpret that it is there alone, it has not spread. Sometimes that's where now you need a nuclear physician, the doctors who are involved with PET scan. So you have to check the whole body. Now once that is done, you take you back now to a surgical oncologist. That surgical oncologist is specialized to remove this mass very well, because removing cancer is not like removing a growth. Different cancers are removed differently so that we achieve a cure. This is not done by one doctor. At that point now, the oncologists come in and people discuss and say, if we remove it like this, this is the best, and then the surgeon removes it. Once the surgeon has removed it, the pathologists now come in again, check it, confirm it is all removed, this is the type of cancer, and they do further tests, which might now involve other pathologists. That's why sometimes we take specimen abroad to confirm it is this cancer, this type, it has this characteristic, and actually certain treatment is what can work for it. Once that is done, now the oncologists come in. And even the oncologists are different type. They'll have to sit as a group and say, if it needs chemotherapy, we go to somebody called medical oncologist. If you need radiotherapy, somebody with a specialization in radiation alone. If it is in the blood, you need somebody called hematologist. After that, then the patient is treated. The patient still believes they may die, so they need somebody to do for them counseling and walk with them the journey, called the palliative care. They may come forward, or they may come at that time. And then after that, now the team will come now following up the patient as they go. Now, chemotherapy has to be prepared. It is not prepared like any other drug by the nurse. It is prepared by a pharmacist, and this is called a pharma-oncologist, a specialized pharmacist, not just the ordinary pharmacist. The nurse who has to give this chemotherapy to go into the body has to be called an oncology nurse. If you go now the radiotherapy pathway, we need to get a specialized person called a radiographer radiotherapist who now are to prepare you through the process of radiotherapy. Then you have to get a scientist who now move from having a physics knowledge to manage the machine to ensure that I give you the right dose and also ensure that this dose goes into you and is going to be given and received by the patient and kill the cancer cell as the oncologists want.
And
so all this process requires so many people.
Let me just take one example.
Yes.
To be an oncologist, how long do you need to train and at what cost?
So to be an oncologist, after you have finished your internship, we expect you to have been a medical officer for 3 years, and then you train for 4 years in the university to become an oncologist. Currently, the average fees is about 600,000. So tuition fees alone cost you 600,000 by 4. 2.4 million.
Hapo hujahesabu ile miaka 6 kusomea udaktari kwenye
yeah, that one no.
Hiyo iko kando.
Hiyo iko kando. Umefanya internship medical officer 3 years. So ni kama unachukua about 14 years from the time umeingia medical school to the time we say you are now oncologist.
14 years to get to that point.
Maybe to add to that is that we need to say that the national government takes care of the tuition at the master's level.
Yeah.
Yes, that is taken care of by national government. So what we need to do is to interest the ones who have an interest in having this as a profession. But we are also discussing then how is it that as a country we get to interest as many people now that we see the cases are so many, yet the specialists that we have are few. So we shall be discussing, I'll be talking to this good expert so that then we get to see what is it that we can do as a government. Many years ago, we had many people dying from mothers dying when delivering. So then the government did an affirmative action to ensure that we have many gynecologists. So that situation has been cured as at now. So the situation that we are faced with right now is cancer and non-communicable diseases. We are going to take a decision, a policy decision as a government to see how is it that we can interest as many people then to be able to go and train in the subspecialty of oncology.
Sam, the missing piece there in that training is that when that doctor is pulled out of the county referral hospital, in those 4 years when that doctor is trained to be an oncologist, he'll still be earning a salary from the county government. Well, he's in college, but he's not working. In the meantime, I do not have money to replace him at the hospital where he was working. That becomes an extra cost to the Mwananchi and to the government. So in the whole of this thing, it is cost after cost after cost.
All right.
But some we must also, for that, I know...
Waziri, I'll allow you an opportunity to respond to that because I think it requires a response. But Dr. Meli, talk to us about now the national strategy, because if you look at the professionals that Professor Ocheng has enumerated there, it's quite a process and it's adding to all these costs. What is the biggest strategy to ensure that, yes, we may have more centers, but they'll also be having the HRH? That they require to work?
Well, thank you, Sam, and thank you, Madam Waziri and my colleagues. I think this issue of cost, to me, the biggest cost we have in cancer is loss of life. These other costs that we are working on reducing are possible, they are manageable. National Cancer Institute of Kenya is currently implementing a sector cancer strategy, which was developed by many stakeholders, and it's looking at from prevention. That is a strategy that we are using to slay this dragon. You know, our pillar number 1 is prevention and early detection. This is where the, primary health care, community health, this is where UHC is really anchored. When we talk about community health promoters, we really want to equip. In fact, in the next 2 weeks, we will be having community health promoters represented by PCN. They will be undergoing a 2-day well-structured curriculum on cancer messaging, and this is going to equip them on basic information that will allow them, be able to educate those who are in their community health units. We have our second pillar, which is diagnosis using pathology, imaging, and radiology, and laboratory medicine in general. If you look at this team, it requires a lot of human resource, as Dr. Cheng has enumerated. Mm-hmm. And what we are doing, Governor Mudomi, we are changing our strategy now of training healthcare workers to avoid getting them out of the counties. We are discussing a proposal where we are going through the collegiate kind of training where if you have a specialist in your institution, we do not need to get away your medical officer. But then we can attach this medical officer to University of Nairobi, and they will be doing didactics, but their clinical experience will be done within the institution, in the county governments. And we will not deprive you as a county this doctor who would still train under the mentorship of an experienced doctor, a specialist for that matter. And not only in oncology, in surgery, in radiology, in gynecology and obstetrics. And that will also cure the problem that you have replacing medical officers again and again. And you replace them, and sometimes they go for training and they never come back. Sure. Unfortunately. So our pillar number 2 looks at this. And as we discussed the cost of cancer care, let me talk about, this one, and the third pillar, which is treatment, with curative or palliative intention and survivorship. There is a lot of infrastructural investment here that goes into increasing that cost of cancer care. If you look at radiotherapy machine, to put up one center, it costs 600 million. To put one basic comprehensive center without putting in a lot of investment, which would be ideal, especially at this level when technology has really changed practice and has been used to improve quality of care, to make sure side effects are less and to make sure there's precision oncology. When we talk about CyberKnife, we are talking about 750 million investment going into, treatment that has, precision oncology, where we are treating patients to as close as 1 millimeter. I do not want to go into the details of science here, but then the cost of investment in this, for us to have, to sustain these services, including maintenance, for us to sustain these services, we definitely would have, it comes with a cost. If you look at targeted therapies, and right now to treat cancer, we are also modulating the immunity. We are doing what we call immuno-oncology. You get one drug, every 3 weeks it's costing 850,000 shillings. Who can afford that for life or until death or until progression of the disease? So treatment, diagnostic, there is a lot of investment. When we look at the cost, and we are happy at least social health authorities stepping in to support in full. And I agree with Madam Waziri that we have to pay. We have to ask Kenyans to contribute. We have to be responsible for our health. If there is any taxes that are, returns are almost immediate, it is this one. As much as all of them are important because it contributes into quality of healthcare in general. Pillar number 4 that we are looking at as our strategy from the sector that we are implementing is on advocacy, coordination, partnership, and healthcare financing. And this is relevant at this point. We have to get resources. Our strategy is cost at 49 billion over the next 5 years. And for us to be able to implement this strategy to the latter, we need resources. And this is where now we are bringing together all stakeholders, government, non-government, state, non-state actors, including pharmaceutical companies who are also reaping heavily in treatment. We are currently working with Roche, for instance. They have, programs, Roche and AstraZeneca. They have programs that have actually, we call them access programs, accepting a drug that could, Kenyans could not afford. Affordable. Right now, they are getting it at 33,000. When it came into market, Dr. Ocheng and Dr. Busakala and us who've been in the practice for quite a while, when we started our practice, nobody could afford that drug because we were looking at 500,000 shillings. But right now it is at 33,000 and it is covered by NHIF comprehensively. It's a life-saving drug. And we are looking at treatments for lung cancer, which these pharmaceuticals have subsidized, and also prostate cancer. So we are having that discussion to make sure that anybody who is investing in cancer care, we can cost and know it is it's going to reduce this. And we are engaging into more access programs. That is the direction. It's one of the strategies, as we also do pooled procurement for cancer drugs. Very important, because when we, economies of scale would definitely reduce the cost, and that cost will be reduced for the patient, what they are complaining about. And the last one is cancer surveillance, registration and research.
Asante sana Dr. Meli. Umejibu swali ambalo alikuwa nalo Muthoni Njuki.
Hajajibu bado.
Mambo ya madaktari.
Hajajibu. There's a very important issue about, they are talking about diagnosis all the time. In the county governments who are relying on MES equipment, which program is coming to an end, Waziri is aware of this by next year. If as a government we don't do anything about it, either from national or county, then that issue of saying that we can select the dragon of cancer from the village level is going to be a thing of the past. Because it will mean that there will be no CT scan that will be working in the counties in this country, no MRI, no X-rays, no those theater equipments where we need the surgeons. And therefore we need to invest in those pool equipment as a country, so that we can be able to take care of the same.
Bila shaka maelezo ni mengi. Sam?
We have to cross over to Jael, who is speaking to caregivers at the palliative care. Jael, over to you.
Thank you, Sam and Christine. And the cost of care does not just stop on treatment. It also comes in matters of management. And we just want to get to understand what this cost, what does it involve? And maybe Elsie, you can help us just digest that and get to know what are the costs involved in caregiving or palliative care.
Thank you. Thank you so much, Jael. When we come to palliative care, luckily it is not as expensive as treatment. We've talked about very big numbers when we're talking treatment. But when it comes to palliative care, we're talking managing side effects, we talk managing symptoms, which is very pocket-friendly, if I can put it that way, or rather not even half a quarter what we're talking about when we're talking active management. We're talking when we're doing home visits. When we visit a patient who has a wound that needs management, we try as much as possible to manage it in a pocket-friendly manner, that everybody is able to get palliative care, if it is at their comfort of their home or at the facility. That we try as much as possible. Everybody should have pain management. Nobody should at this era be screaming that nobody is sleeping in the environment. Should be able to sleep comfortably if they have enough money in their pocket or they don't have money. So it is very pocket friendly.
Thank you, Elsie. And Dr. Zipporah, you said about the issues of cost of treatment. Some of them are just on paper, and reality, as people say, reality on ground is totally different.
Yeah, sometimes actually we pass laws and regulations, but we don't walk the talk. So we've heard from the patients today, they have talked about the fact they have to dip into their pockets to pay for their treatment. And that is still the same. Even today, like one lady said, we have a patient who's asking for help. We have a forum where we talk with patients and everybody. And she has been in the house because she can't afford her treatment. So I'm hoping, as the CS has said, that this new system, the Social Health Authority, is going to focus from conception probably until whatever the journey of your life is. I'm hoping that it will include palliative care, because one of the things that she has talked about, the hospices do home visits. They go and see patients at home. This cost has not been paid forever in this country. How can we also ensure that these costs are taken? One of the things I said earlier on is palliative care costs a lot of costs. Patients come because their needs are not being met. But when you meet their needs, they will stay at home. They will not keep on coming because I have pain, because I've got a spiritual issue. They will stay at home, and the cost is cut for the patient, for the healthcare facility as well, and for the healthcare system. So one of the things, is she says it's pocket friendly, but sometimes the patient may need chemotherapy or radiotherapy or surgery that we call palliative, and this can be costly for the patient. So my hope is that the government is going to look at how they can also pay for hospice care, because hospices do a lot of good work. work. One of the things we did to minimize costs in this country through the Kenya Hospitals and Palliative Care System is to integrate palliative care into the healthcare system. So it's fully budgeted for. It's part of the ongoing service in a health institution. So integration is still very important as well.
However, now for Jacqueline, you say at Kimbilio, the cost of palliative care is subsidized. How subsidized is this? How much is that?
Yes, asante sana Jael. Kama nilivyosema kwamba gharama ya tiba Shifa iko chini kuweza kulinganisha na gharama ya matibabu. Kwa mfano pale kwa hospice Kimbilio unapata kwamba gharama ya kushughulikia mgonjwa kwa siku moja ni takriban shilingi 2,500. Kwa hivyo wageni wetu wanalipa kitu kidogo tu ya kuweza kuwasaidia. Na pesa ambayo iko juu si kwamba ni bure. Kuna mtu mahali anagharimika ili aweze kusaidia huyo mgonjwa. Kuna hospitali nyingine yetu kule Eldoret ambayo inaitwa Living Room Hospital ambayo pia imeanzisha mtindo maalum ya kuweza kuwasaidia watoto ambao wako na saratani. Watoto chini ya miaka 18 wameweza kujengewa nyumba ambayo inaitwa Mika Guest House. Nyumba hii wanakaa mahali pale bila malipo. Wanakaa wakienda kupata matibabu ya saratani kule hospitali ya rufaa ya Eldoret. Wanasafirishwa na gari ambalo pia ni ya Living Room. Wanaenda kupata matibabu, wanarudishwa mahali pale. Na chumba hicho kiko na vitanda 40. Kwa hivyo inaweza kuweka watoto kama 20 hivi pamoja na walinzi wao. Kwa hivyo ndio njia mojawapo ambayo imeweza kusaidiwa kuweza kupunguza gharama ya matibabu ya saratani.
And you know, on the other aspect of palliative care, and this is one issue that becomes difficult, it's difficult to talk about, is the issue of death. But we all know that at a certain point, unfortunately, some of our cancer warriors would have to succumb. And there's that element, you as caregivers or palliative care involves preparation for what you call end-of-life care. Dr. Zipporah, what does that entail, and how do you walk both the patient and the family through that?
Okay, yeah, we all die, so that is a reality. I mean, that's the only figure that has remained the same, that 100% we will all die one way or other. And sometimes our patients do get sick, and we know that they're probably coming to the end of life. And it's very important because I think as a doctor, a palliative care doctor, that end of life is actually the biggest part of me as a healthcare provider that I need to invest in for a patient, because we have nobody has died before. It's very new for them, it's frightening. And so we really have to support people who are dying and their families. And specifically, being able to talk to a patient about their prognosis. This is something that we don't talk about in this country. We try to beat about the bush, but sometimes patients want to know if they are going because they have unfinished business they need to address. But one of the things we factor on is that we talk about a good death. Death can never really be good, but a good death is a patient who is dying in peace, has made peace with their family, has no symptoms, or their symptoms are minimized, they have been controlled, they are peaceful. If they want to die at home, then they should be dying at home. If home is not a very conducive environment, then probably an institution. So really meeting the patient's needs and maybe trying to find what are the goals of care at this point of time to make you comfortable. So it's about comfort, it's about dignity, it's about not suffering through your death, it's about being surrounded by your loved ones, and it's about caring for this person. And so I always think that death is really a hard time for any patient and family members. So comfort for the family. Even for us healthcare workers, we need support during that time. We get attached to these patients.
Exactly.
And so sometimes nobody's taking care of our feelings. So we really also just break down sometimes.
And that's where I wanted to ask about your own psychosocial support. How is something put in place for your own mental and emotional well-being? Maybe you can help us with that.
Thank you. Yeah, one of the main things we do, if you want to take care of someone, a patient, take care of yourself first. If you really want to give quality, have quality. So the main thing in most of the facilities, especially the hospices, we have put in place systems that support caregivers, healthcare professionals, so that you're in good status of mind to support a patient completely.
Exactly. And this is something that maybe we skipped, but it's important to look into the issues of nutrition, even as you're managing these patients. Jacqueline?
Yes, hali ya chakula pia ni muhimu sana kwa kushughulikia wagonjwa, kwa sababu napata kwamba itakuwa vigumu sana hata mgonjwa dawa kuweza kufanya kazi ikiwa hana lishe bora mwilini. Kwa hivyo ni sehemu ambayo pia imeweza kuzingatiwa sana kuhakikisha kwamba wanapokuwa pale kwa hospitali wanapata lishe bora, na pia kuna watu ambao wanashughulikia hayo masilahi ya lishe bora. Kwa hivyo ni jambo la muhimu sana kwamba wanapopata dawa hata za saratani wapate pia kupata lishe bora. Ni jambo ambalo ni muhimu sana katika hospitali.
And then how long will someone stay in palliative care? Do you always consider that when you've walked with a patient and at a certain point you make a decision that they're no longer eligible for palliative care?
Sometimes patients become very attached to the team, so you can't just tell them we are done with you. And we know that sometimes cancer occurs. What we usually advise is just having an open door, policy. A patient can walk in and walk out as they see the need. Patients might feel very well and forget about coming, and they might also not need to come. But we should have an open door policy because the patient can have a recurrence. The side effects of the treatment can also be very prolonging, can be very devastating for the patient. So issues of survivorship, rehabilitation are still part of what we do in palliative care. So we don't really say that now go away, we are done with you, because they might not have the disease, but maybe the fact that their body was, damaged might be really hurting them. So they want to come and talk to somebody about that. So it really, I think it's just a continuum of care, what you're talking about. A patient should be able to access services whenever they need them, wherever they are. And that's why it's important to take these services closer to the community so that they can access them wherever they are.
Exactly. And that's where there's the involvement of also the family members in matters of caregiving. Thank you very much. And right now I'll hand you over to the expert studio where we have Victoria and Nimrod.
Thanks for that, Jael. I'll cross quickly to Dr. Catherine. You've been hearing from all the stakeholders, but I want to talk about positive outcomes, especially when it comes to treatment. And there's a wording that we hear, remission and cured. What do those two words mean? Because you'll hear a patient say, I'm in full remission. Many times they feel, oh, I don't need to come back for any more checkups. The draining finances are no longer something I have to deal with. So when you talk about those two words, what does it mean to be fully cured from cancer and to be in remission?
So for cancer, it is a chronic disease. And sometimes you can go into remission, which means you are free of all the symptoms and of the cancer. They've done all the imaging, and it cannot be detected. But we encourage patients to go for follow-up. And the longer the survival is, the higher the chances that you are actually cured of the cancer. So it's always good to be on very close monitoring and go to your doctor, take your medicine as prescribed, so that if you are in remission, we also aim to have a cure for the cancer.
What happens in those cases where the cancer comes back but more aggressively?
So cancer can come back without a warning, and it's important that you see your oncologist to check you and treat it efficiently and in a timely manner. Some patients assume that what they are feeling could be the side effects of the treatment for a long time, when actually the cancer is coming back. So always it needs a medical attention. See your doctor to differentiate between side effects and the cancer coming back, so that when it comes back, it can be detected early and can be treated in a timely manner, because when you take long also to get treatment, then it spreads and becomes more aggressive. And cancer is different in every person. There are also different types of cancer. Even breast cancer is not the same between one patient to another. They all have very different behaviors. Some are aggressive, others are not very aggressive.
Daktari Noela, kwako yeye niulize kuhusiana na vipimo vya chembe-chembe. Masaa ile mnafanya pathology, kujua kiwango cha kansa kimefikia wapi ama staging. Ni wapi ambapo inakuwa ghali kwa mgonjwa ili aweze kujua ni matibabu gani anayopitia? Pili, je, kuna teknolojia ambazo zinaweza kutumika kwa sasa hivi? Kwa sababu mara nyingi utakuta kuna mgonjwa ambaye ana saratani, akienda na katwa sehemu fulani, iwe ni titi, ili kuweza kupimwa. Ikiwa atafanywa tena ukaguzi kuweza kujua stage imefika wapi ya kansa, lazima tena akatwe sehemu nyingine. Huone kwamba hii pia inaleta unyanyapaa ambao ni stigma, na pia ina gharama yake. Je, kuna teknolojia ambayo inaweza kutumika ili staging iweze kuwa rahisi kushinda kuweza kumkata mtu sehemu tofauti kuweza kupima chembe-chembe za saratani?
Acha nijibu kwa Kiingereza.
Tafadhali endelea.
Kwanza saratani lazima tuchukue nyama. So it's what we call invasive. We have to take a sample of what Dr. Ochieng called meat. We'll call a biopsy in this case. So it's a piece of the tissue of the growth or the cancer that we're talking about. And what happens is, as you heard, we come in at 2 stages. So the initial stage is when we take a small piece. We first want to establish, number one, is it a cancer? And if so, what is it? Yeah. And then based on that, we then decide, do we go in and remove the bigger section of it? Because we've just taken a very small piece. And that's what we call an incision biopsy. When we go and remove the whole tumor, we then call it an excision biopsy. And that's why it's a very intense, multidisciplinary team approach when you're doing cancer, because the surgeon is involved.
Ambayo inafanya gharama yake inakuwa juu.
Inakuwa juu. No. Yes, so you have the surgical procedure, you have the biopsy being brought to us. When we receive this biopsy, we have to establish what cancer is it, number one. And then we have to do what we call subtyping. As Daktari has said, we have different modalities of treatment for the different types of cancer. For example, for breast cancer, we have almost over 20. So we have to establish exactly what type. And so one of the warriors talked about ductal carcinoma. That's just but one of the types. So we have to establish what type it is. And we have to go into very expensive testing. We do immunohistochemistry and other tests. And this is why gharama inaju.
Na ndio maana nikauliza, hatujafikia mahali tuna teknolojia. Badala mgonjwa aje kila wakati unapompima kujua stage, lazima umpeleke katika chumba cha operesheni. Hapo kuna gharama. Hakuna njia ambayo tunaweza kuwa na teknolojia ambapo sio lazima mtu kukatwa sehemu fulani ambao gharama yake iko juu.
So sasa we have the cryosurgery, the surgical therapy that is now available in KU, and the liquid biopsy. And we also do FNA biopsy. Not all require surgery. And this is why it's hard to generalize cancer. All cancers come with their own specialized treatment. We can't generalize. But it's true, some do not necessarily require full surgery. If it's benign, it may require just management with drugs, and that's it.
I mean, let's talk about how cancer treatment has evolved over time. Dr. Catherine, I'll come back to you. What have we found in terms of how maybe ethnicity plays a role in how individuals would respond to medication? And are we now calling for more locally based, curated research for us, for Africans, to be able to respond better to cancer treatment?
Yeah, definitely there's a lot going on in our country in terms of investing in infrastructure, which you've seen happening. In research, we have many bodies really focusing on research and on training. Like at the University of Nairobi, all the doctors doing oncology have to do research, which is now customized to us. And as a matter of fact, currently I'm involved in a research whereby women with breast cancer, we are trying to differentiate between going for 3 weeks versus 1 week of treatment. And this is just using conventional radiotherapy. And there's a research that is going on courtesy of Kenyatta National Hospital and University of Nairobi. And we want to see whether what the West are doing, treating their women within 1 week, can work in our community. So we reduce the burden of cancer on patients. We've seen that patients encounter a lot of barriers, like financial barrier, a physical barrier. Even just having somebody to take you to hospital is a problem. They also encounter lack of knowledge. And I think the forum today is very good because it has opened up a lot of knowledge and awareness to the community to really know about cancer. And maybe before I finish, I would like to say that as Texas Cancer Center, we also try to just offer localized solution to deal with the cancer menace in our country, reduce the cost of cancer care. NHIF has contributed immensely to cancer patient care, and I'm really grateful. And with the shift to the new shift system, I'm hoping that it will even, cancer patients will stand more to benefit on the same. Yeah.
Daktari Gladys, utaniwia radhi. Kuna dakika ambazo nitakupa wewe kuweza kujibu maswali na vile vile Roslyn. Lakini kwa kifupi tu tuelekee aliko Lilian Muli. Tunaarifiwa kule hali ya anga si shwari, maanake wako katika studio ya muda nje kule katika chuo kikuu cha KU. Wacha tuende kwake Lilian Muli aweze kuzungumza pamoja na wataalamu, madaktari wanaohusika na masuala ya saratani, halafu turejee hapa kwa mawili matatu.
Many thanks once again, live from the Kenyatta University Teaching, Referral and Research Hospital. We want to get the final talks, the final thoughts of our experts in studio this evening as regards the latest technologies in cancer diagnosis and treatment. To you, Bwana CEO, Mr. Ahmed Dagane, let's talk about the cancer burden in the country. We've had our panelists in studio, the cancer survivors and the persons in palliative care talking about how huge the cancer burden is in the country. Is this facility able to cater for the demands of the patients that come here seeking treatment? What can you tell us about possible waiting lists and indeed the demand in terms of numbers of the patients that come here?
Thank you. Thank you, Ms. Muli. It's good to be back to further discuss on the big conversation tonight. As I talked about earlier, we are seeing an increased number of cancer patients. I've said earlier, we're treating between 800 to 1,000 patients a day in our specialized clinic, and most of those patients are cancer-related patients. And so, as a hospital, we thank the government through the leadership of our cabinet minister, because this is a highly specialized institution that is able to mitigate some of the gaps that we have in the country. But we're trying. We are treating patients for radiotherapy. We have seen those increased number of patients, and it has forced us to start a third shift. So instead of having 2 shifts now, we have an additional shift.
So you run the radiotherapy for 24 hours?
Yes, we do run for 24 hours. Of course, there's a waiting list, but again, through the leadership of the cabinet secretary and the hospital board of management, we're going to acquire a second LINAC machine very soon to be able to take care of those patients. So we are doing our best as a highly specialized hospital to be able to mitigate some of the gaps.
In terms of the waiting list, we know that there are stage 4 cancer patients who do not have the luxury of time. So in terms of the waiting list, do you prioritize in terms of how advanced the cancer is?
Absolutely, absolutely, yes. Those patients who are really sick are prioritized. And then we also, we do have daily clinics, so some of the patients are being seen. There are also other treatment modalities going on. We have the oncologist specialist here in the hospital. They're able to see those patients and prioritize according to how sick they are.
Right, and as I proceed with the rest of the panelists, advancements in terms of research, you say you have a huge cancer burden in terms of a waiting list and not enough equipment to cater for the demand as well. So advancement in terms of research and where you are at as an institution.
Yes, thank you. A great question. As an institution, actually, we have a robust research activities going on in the country. We have excellent partnerships that we have incorporated. An example is there's an ongoing research through a partnership with the University of Manchester and the Christie Hospital Foundation in the UK. We have done a joint grant together on esophageal cancer. So that is one of the cancers that are researches that are going on. And then, of course, we have partnered with local institutions like KEMRI. There are several research studies going on in the institution. And so through partnership, collaboration with both local institutions and some of the leading healthcare organizations across the globe, we have a robust partnership. In fact, as our name suggests, we have a whole directorate in charge of research.
Thank you for that. Now, Dr. Helena, we had spoken about the breast cancer comprehensive care that is found here, and I'd like us to go back to that issue as regards how timely it is in terms of when you get the results and what exactly happens in that particular center.
So we have the Comprehensive Breast Care Center, which is a novel idea in the country, was launched, it's just about a year old now. And we're able to cater to both men and women who have got breast cancer or breast care concerns. And so it's a rapid results initiative clinic, and we're able to make a diagnosis within 60 days and initiate treatment as well within that time. I think we're doing better than that target that we were given of 60 days, and we're diagnosing and starting treatment earlier than the 60 days. And we're able to do everything. So we're able to screen our patients. We have ultrasound, mammogram, MRI. We have got pathology services available where we can be able to get the biopsies done. We also have got nutritional support. We've got counseling support. we have an active support group where we are able to cater for those that are survivors and those that are going through the journey with breast cancer, to be able to, get some strength through others that have made it. And then we also have palliative care. And then with the other treatment modalities, we're able to offer chemotherapy, immunotherapy, as well as radiotherapy to these patients. We also have 2 dedicated breast surgeons and are able to offer specialized breast surgery for these patients.
Right, and on the other leading cancers as well, which would be the cervical as well as the prostate, do we have any advanced technology that patients can find here?
Yes, just touching on cervical cancer, we have a screening program. It's unfair to have a woman walk in and only screen for one cancer. So we're able to screen not just for the breast cancer, but also cervical cancer. We know that these are the 2 leading malignancies in women and also the highest cause of mortality in terms of cancer deaths in the country. And so we do offer cervical cancer screening. And for those that have early lesions, we're able to treat them in the pre-invasive stage. Those that are diagnosed with cervical cancer, we have a gynae oncologist available in the team, and we also have treatment options available. For prostate cancer, we have diagnostic facilities where we have the PSMA PET CTs that is specific for prostate cancer, and we do have options to treat the prostate cancer as well, including the CyberKnife.
And Isaac, elaborate on the affordability of cancer treatment and medication found here, because affordability continues to be a huge concern, as you've had from our cancer survivors in studio and those that are still undergoing treatment. In terms of the NHIF, will it be able to cater for patients that are referred here, and in terms of future visits as well? Is any Kenyan from across or even far-flung counties across the country able to access treatment here? And if not without the NHIF, will this institution be able to cater for the Mwananchi?
Thank you. Thank you once again, Lillian. Yes, we are a national referral hospital, and we are open for referrals from all over the country. Just to let you know, majority of the patients we see at the Molecular Imaging Center and our Oncology Center actually don't even come within the counties around Nairobi. They come from as far as Garissa, Kisumu, Nairobi, Kisii, Nakuru, just to come and get these specialized services. And I'm glad that our National Health Service Fund is able to support especially this complex treatment. I'll talk about the Molecular Imaging Center, where they do PET scans, and the most recent one, the CyberKnife. We have I just want to mention that recently they also included brachytherapy, because initially it was not being covered by NHIF, but after discussions with them and also with the input and the support of the National Cancer Institute, we have been able to convince NHIF to include that, because it is an important modality of treatment as part of cure for cervical cancer.
Right. Gentlemen and lady, I thank you for your time. But very quickly, Keflom, the importance of early diagnosis as we hand back to studio. The rain is not on our side. Let's get your final thoughts very quickly. Inform us on the importance of early diagnosis and how far this goes as regards better treatment outcomes.
Yeah, thank you very much for the question. So the importance of early diagnosis is that, if you could be able to detect the cancer early, which means there is a probability of getting cured. So being part of the Integrated Molecular Imaging Center as a nuclear medicine physician, our imaging facility also has a role in detecting those cancers early, so that they will get early treatment. So, which means early detection of cancer means getting the probability of being cured from the cancer. Yeah.
Many thanks for your time once again, gentlemen and lady. We've been coming to you live from the Kenyatta University Teaching, Referral and Research Hospital. Remember, it is a referral hospital, but with your NHIF, you can get treated here. Do not also stay away if you do not have an NHIF cover or card. Simply walk in and you'll be advised on how to go about getting treated here. Remember, this institution made history after performing the first non-invasive CyberKnife surgery, and it is a first of its kind in this region. Back to you in studio.
Great, thanks so much for that, Lillian. Back here to our experts, Rosalind, let me come to you because, we've been talking about the financial cost of treatment. There's also the physical cost of treatment. When you talk about radiotherapy, chemotherapy, it drains patients, and there's several side effects that come with. How do you help them manage the side effects? And are there some alternatives that help them kind of bypass a lot of those physical outcomes?
That's a good question. So cancer treatment, as you've heard, are quite varied, and each one would come with its own side effect. So one of the things that the nurse at the clinical setup usually need to do is to do triaging and find out what are the patient's concerns so that they may be able to document them down. And sometimes you realize they have fears. They even don't want to go through that treatment that you are proposing. So the first thing then is to give them education. Educate them that each cancer is different, treatment modality is different, and even the outcomes are varied. So you give them that and you tell them whatever the side effect they're going to face, you're going to be able to give them support. For example, the immediate one will always be nausea and vomiting. And at that point, the doctors are able to prescribe the drugs, and of course, the patient is able even to continue with it at home. Another challenge they have is low blood count and even low immunity. And that you prepare them to ensure they eat well, and that nutritionists must be involved depending on the type of cancer. You realize some are even oral cancers. That means they need to be examined alongside even the ones that have the gastrointestinal cancers. They have to be supported even through other models of feeding. Then that comes with low immunity. So you tell them that you're likely to be susceptible to infection, therefore avoid crowds, eat well-cooked food, and then blood checks are done like every 3 weeks, depending on the cycle. And should there be low immunity that is detected and the low blood counts, or rather low white cell counts, then they're given the drugs that support the immunity. So patients are, if you prepare them well, they also anticipate and they're willing to collaborate. And I always say that all this need to be documented in a way that even when they go home, they have a reference that this is my type of treatment, this is what I expect. And that comes to systemic. Then you go to the hair loss and, of course, breast loss. Those are body image challenges. Again, the society need to be kind to people. Embrace them. Don't, if there's anything you can do to somebody, even to provide a wig, do so. A prosthesis, you saw a simple one, avail it to a patient so that they have the confidence to continue. Then you get into issues, perhaps radiotherapy, that we now talk of being more precise. And then now there are the skin changes that would come along with it. And you want to tell the patient to be able to report the side effects early enough so that they are treated. Then it comes to issues of maybe reproductive health cancers, prostate and maybe cervical, and most of cervical. Here you're giving maybe brachytherapy. It's going to affect their sexual performance. All these things, you do counseling with the spouse together. Palliative care nurses do a very good job in this, and given a chance, the patient and the family are prepared, and they're able to just cooperate through the process. So quite a number of side effects, of course. But again, coming to another challenge that I've experienced, especially with the men who have breast cancer and sometimes prostate cancer. We've talked of hormones being triggers to certain cancers. So you realize this man is maybe turning 40, 50, and then you're starting them on these anti-hormonal drugs because their cancer is releasing hormones. So you give them and you're telling them, yes, it's going to draw you into early andropause, and therefore you link them into a support group. With their fellow men, they know how they can discuss and support each other. But of course, it's a painful thing to most men, but they need to be told. And even if you tell them, they'll come and tell you, know what, today I even started having my hot flashes during that experience. And you can talk over it, and they gain confidence, and they adhere to their treatment. Yeah. So one of the most important things is assess and know what is the patient's need, then educate them, and do follow-ups. Even if they're done with the active treatment, with the regular clinics, they still need to come and just report, and even to monitor even their blood levels and the late side effects that would come.
Asante sana. Daktari Gladys, tunapozungumzia mambo ya radiology, tupe mtazamo wa gharama session moja tu ya kufanya session ya radiology kwa mtu ambaye ni mgonjwa. Pili, zungumzia athari zake. Na tatu, wakati wa matibabu unakuta kuna mtu ambaye anaugua saratani kwa mfano ya titi, anapata chemotherapy, lakini kwa wakati huo huo pia anaanzishwa radiology. Ina manufaa gani?
Okay, I will talk about radiology imaging in terms of the imaging, whereby we are concerned more in terms of the screening, in terms of the diagnosis, because we come in also at that stage. But when it comes to the tissue diagnosis, then that's the pathologist who does that. In terms of staging, how far has the disease gone? Is it just localized or has it gone to a different stage? Because most of the diseases, if they're in stage 1, at least that one with just surgery, one can actually achieve a cure. Then when it goes now to stage 2, 3, then depending on the type of cancer it is, then there are different other it becomes multidisciplinary, whereby you have not only surgery coming in, but both radiotherapy and chemotherapy, oncology comes in and to do that. Now, in terms of, let's say, like doing a CT scan for imaging, in the public sector, it's usually around 8,000 to 10,000, just imaging, to get a diagnosis. When it comes to radiation therapy, that is actually the docket of Dr. Nyongesa, and she will let you know about that. Okay. Some cancers, especially for the gynecological cancers, in terms of imaging to see them well, to do a staging, especially when they're still within the region, the primary area, then you do an MRI. And MRI, again, in the public sector is around 16,000 shillings. So again, that, of course, can be a little bit more costly. And NHIF at least covers for one MRI within a family. So you can see how sometimes it can be challenging if more than one MRI is required. And again, but it also covers for PET. So if we need to do, like we have done the staging and you want to do PET for overall staging, PET CT, then again, also NHIF can cover for that. Yes.
Asante. Pengine Daktari Nyongesa, kufululiza wakati wa matibabu tunazungumzia radiation na vile vile chemotherapy kwa wakati mmoja. Athari zake ni zipi? Radiation inafanywa wakati gani na kwa viwango gani? Na pia zungumzia gharama yake.
Shukran Nimrod na Victoria kwa hii nafasi. Radiotherapy ni aina ya matibabu ya kutibu saratani kutumia miale ya stima ama x-rays, na huwa inapeanwa kwa sehemu fulani ambayo iko na ugonjwa na iko localized. Na kwa nini tutumie radiotherapy? Kila matibabu tunapeana huwa iko evidence based, yani kuna utafiti umefanywa na umeonyesha kwamba hiyo matibabu itasaidia mgonjwa. Kila matibabu iko na hatari zake, lakini uzuri wake unazidi hatari, yani the benefits outweigh the risk. Na radiotherapy session moja hapa Kenya inagharimu kati ya shilingi 3,000 mpaka 10,000 kulingana na hospitali labda ile umeenda, na pia vifaa pia huwa kuna advancement in technology. Na hatari ya radiotherapy inalingana ni wapi unachoma. Kwa mfano kama ni kwa head and neck area, utapata vidonda kwa koo, utapata rashes kule kwa ngozi ya head and neck area. Kama ni kwa pelvic area, kwa mfano mgonjwa ako na saratani ya cervix ama ya prostate, wanaweza pata infertility, yani kukosa kupata mtoto baadaye, sababu zile rays zina affect zile ovaries na maybe reproductive organs kwa mwanaume. Lakini vile nimesema, the benefits outweigh the risk na iko evidence based. Kuna saratani tofauti ambayo unahitaji kutumia hata chemotherapy, na chemotherapy ni dawa ama chemicals, zinaweza peanwa kwa mshipa au umeze ama udungwe, na zote ziko pia na umuhimu wake, na pia imefanywa utafiti na imeonyesha kwamba inaweza ponya saratani. Na hizo matibabu zote mbili, chemo na radio, they are life saving treatments. Chemotherapy iko tofauti kulingana na ugonjwa, na kila ugonjwa, kwa mfano breast cancer iko na different protocols. Unaweza pata hata ina 10 ya protocol. Sasa daktari ataangalia aone ni gani inakufaa. Na chemo ina vary cost between 10,000 to millions of shillings kulingana na ni dawa gani umetumia, ni immunotherapy au ni aina gani ya dawa. Na athari zake huwa ni unaweza hisi kutapika, nywele kukatika, usikie appetite iko chini, na pia uone tu yani mwili yako ni iko dhaifu. na wakati unapata chemotherapy daktari atakupea dawa ya kusaidia na hizo side effects, na hata radiotherapy utapewa dawa ya kukusaidia kukopa na hiyo treatment.
Asante. Kwa kuwa tunamalizia, nitampa mwenzangu nafasi pia na aweze kuuliza maswali ya mwisho tu. Lakini daktari, unafika wakati ambapo saa nyingine kama daktari kuna mgonjwa huwezi tena kumsaidia kwa kumpa tiba. Nipe hisia zako za kibinafsi. Wakati huo huwa mgumu namna gani kwako wewe na pia kwa mgonjwa ambaye tena huwezi kabisa kumsaidia kwa sababu saratani imeenea na hakuna dawa ama tiba inaweza kumsaidia?
Yes, ni ukweli, na ni daktari ni binadamu, hata nurse ni binadamu, na huwa inafika mahali tunashindwa na sio rahisi. Ukiona mgonjwa amelemewa na ugonjwa na wewe huwezi ukamsaidia, sasa inatuadhiri, na wakati huo pia huwa tunapenda ya kwamba tuende through counseling, debriefing, sababu yenyewe umeona mgonjwa wako hapo na uko helpless. Uzuri ya kwamba tuko na multidisciplinary, kuna support system. Unaweza refer huyo mgonjwa palliative care, unaweza mrefer kwa counselor, na pia uongee na familia, waambie ya kwamba hapa penye tumefika tunaona hakuna haja ya kuendelea na active treatment, na familia pia kwa accept hiyo huwa sio rahisi.
Asante.
Thank you to our experts. We're about to now cross over to the town hall where our cancer warriors are standing by with their stories there. Trevor and Rashid, over to you.
Well, thanks, Vicky and Nimrod. And before we take our final remarks here, Mary Mwangi, I'd like to bring you back before you give us your recommendations in terms of what more needs to be put in place to ensure there's effective treatment of cancer going forward. When there was a conversation on palliative care, we could see most of you shaking your heads. What was the concern, Mary?
Okay, the concern, Trevor, is especially there at the initial diagnosis. There is a lot of terminology used by the doctors. I love them, but I wish there is a way whereby they explain some of these terms. For example, I had a case. A patient received a result in December, and by September, she had not started going to the hospital. Reason, she was told, you'll do surgery, chemotherapy, radiotherapy, curable. She didn't know what that was. So she went home and she just kept the result there. Until one time I talked with the daughter, and the daughter told me, I don't know why my mom is swelling. So I went to see the patient and she showed me the results. That's when I intervened. So I wish the doctors can explain in a simpler language understandable to the patient, so that from the word go, they will know what is expected of them and what they need to do. Another problem we are having is when screening is done, there is no follow-up. For example, recently we had a screening in a well-reputable big hospital, but when some patient went back for the results, there were no records. So what does that mean? Is there any need of screening, and a lot of money was used, then you say there are no records.
Shukrani sana. Nataka kumleta Elijah Msau aweze kuchangia katika hii mada yetu za kuzungumza, kwa sababu saratani ni ugonjwa ambao kwa kweli tunapambana nao vikali sana. Ukiangalia dada zangu, mama zangu wako hapa ndani, lakini kuna baadhi tunapokuwa tunawahudumia, kuna baadhi ya matamshi ambayo si vizuri tuwatamkie ama tuwaambie, kwa sababu yanawavunja moyo. Na huo ndio ukweli ambao umejitokeza katika mazungumzo. Unaweza kutuambia vipi kwa wale ambao wanahudumia watu wenye saratani, namna ya kuishi nao na kitu gani cha kusema, kitu gani cha kutosema?
Thank you so much, Rashid, for having me. Let me speak in English. One of the things we were told is that palliative care should begin at diagnosis. And this is where the palliative care experts come in. They break the bad news. That this is where what you are suffering from. In a very systematic manner, we break bad news in mind that we don't break the heart of the patient. We explain to the patient with a very simple language. Simple language is not English or Swahili, but a language they can understand, so that they make informed decisions because they need to go to the next level. So most of the time we find that, and most of the patients we meet, as our colleague have said on the other side, it's true that it is supposed to be referral at diagnosis, but you find it's not being done. So most of the patients we meet, they have these two stories that this is how Daktari aliongea. It was very hurting to me. I was told I have cancer. I will die very soon if I don't go for treatment. So these are the things we are saying, that if these people are referred for palliative care early at the diagnosis level, we are going to start working with them. And we shall explain to them what they are suffering from, what is possible under the sun. And as things, even if things becomes hard or the prognosis becomes quite difficult, we shall explain to them in a symbol they shall understand. And as my colleague has said on the other side, is that palliative care involves not only the patient, but also the family members, because a patient is not an island. Is somebody's daughter, is somebody's husband, is somebody's spouse. They need to know what is happening, because a husband who has a sick wife is also sick mentally. So they need to be explained to in a language they can understand. That's why palliative care comes in. They are trained in communication skills. Yeah. They have communication techniques which they can employ. And especially when it comes to communication, because communication is not what the patient is saying alone. Yeah. The tone they are using and the language they are using to explain their problem, and also the facial expression, which we normally look at, and then we can now help them. All right. Because we can understand what they are.
Let me bring in David Musyoki on this. And David, what is the best way of handling this information being given to the patient? Because I could see when like Daddy was speaking, Lucy was shaking her head. How do you handle it in such a way that you don't break their hearts? You still give them hope to keep fighting, because it is true. We have warriors here who have dealt with this.
Thank you so much. And I like the big conversation. And as I answer you, I throw sort of a question to us. Are we listening to ourselves? Are we having really a conversation, or are we just answering questions? Because, for example, the things that we've been talking about, and especially identifying with people who are walking the journey, do we sit back and ask ourselves, what were they really saying, and are we doing to, affirm that what they were saying is key and important? I hear appeals from the perspective of, we need care. As a country, are we providing that care? Or are we willing to act to provide that care? Do we have finances as a country? I'm sure we do. How are we using our finances to address the needs of these people who cannot access medicines? Case an example is a medicine called morphine, which is used to control or to manage severe pain. Unfortunately, we are running out of stock for that medicine. From where I come from, the National Association for Palliative Care, we've done appeals through KEMSA and other bodies. But who is listening to us? We're talking about the big conversation. Who is listening to the caregiver who is overwhelmed because they have a patient at home? And so at the end of the day, it's about acknowledging that there is wealth of information here. There are scholars everywhere, and we hold big conferences and big meetings, and there is best practice to achieving universal health care. Do we walk the talk? Are we supposed to be praying, to people? Tunaomba serikali, tutaomba mpaka lini? Tuache kuomba, tuombe Mungu na tufanye ambacho kinafaa kufanywa kama nchi na kama wananchi, alafu we need to be responsive to our needs. And thank you, citizen, for having this kind of a conversation.
Kuna tabasamu uliokuja nayo Lucy, sitaki uende nyumbani kama tabasamu haipo, kwa sababu nimeona kwamba tumezungumza, lakini kuna mambo ambayo kidogo yanafanya tabasamu yako kuondoka kama shujaa. Labda nimpitishie kipaza sauti. Lucy, ni gani ambalo umeona kwamba aliko sawa na ungependeleza kurekebishwa? Maana yake yakizungumzwa kule nje tabasamu limefifia, yakizungumzwa pia tabasamu limefifia. Na mimi nataka ukirudi tabasamu liongezeke zaidi. Nini ambacho
kwanza niseme palliative in real essence wanasema ati inaanza from the diagnosis, na sidhani ni kweli. Mimi sikupata. Na juzi nimeenda katika kituo cha hospitali, nikaambia kuna diapers na morphine. Mimi survivorship yangu haitaji diapers size na sihitaji morphine. So in real essence, hakuna chochote changu. Hiyo ni kitu ya kwanza. Na hii yenye nasema ati wana move na sisi from diagnosis, they need to go back to the drawing board. That is something that we really need to look at. If you ask the survivors, wacha tuulize tu kwa mikono. Nani alipata palliative? Aliambia kuna palliative venye alipata diagnosis. Tuinue mikono juu. We talk about data, not opinion. That is the data. You've seen nobody. So you have Mr. Wambua, kuna kazi ya kufanya. Nimefurahi, at least we've moved from somewhere. During my time treatment na wakati huu, there's a lot of improvement and good things that are happening, but we can do better. Ile kitu imefanya uone sura yangu imebadilika.
Na sitaki ibadilike, ndio maana kupa nafasi.
Na ndio maana nimesema, na si mimi peke yangu, ni hao wote. Kuna mtangazaji pale amesema ati kuna mali nafika hawa kansauri wanakufa. Everybody is on transit. In 100 years, nobody will be here. That is profiling. Na hiyo ndio kwa kijiji wanasemanga ule mama wa. Na unapata remorseful survivors, it is not covered. I can lose a friend of mine and I won't go for the burial because they'll say that ata ule yako kwa. So her saying that our survivor warriors pia wanakufa, it was profiling. So please, for emotional healing, we have those emotions and they run high. Right now, you saw everybody here was up in rolls. Mbona anasema tunakufa? Si pia wao watakufa. So kifo is a sure bet for everybody, not for us alone. And then, for emotional healing and mental health, most of the survivors, umepigana na saratani, lakini unapata depression. Unaenda unajirusha kwa mto, ama unakufa, ama unafanya vituko. Imeangaliwa? Haijaangaliwa. Kwa hivyo tuna survive after that, after the trauma. Watoto nyumbani, ngoja nikukate, watoto nyumbani. Mimi niko na watoto, uko na watoto. Wameona ugonjwa na mama yake ameadhirika kifedha na kimawazo. Hao watoto wetu wanaangaliangwa na nani? Wanaongeleshwa na nani? Unapata watoto wanaenda huko nje, wanakunywa pombe ama wanafanya vituko ama wanakataa shule. Kwa hivyo let it be wholesome. Si mimi peke yangu. Pia wao na hayo mambo mengine.
Na kutoka kwangu na mimi kama kuna kauli ambayo imekugusa na imewagusa wengine, tunaomba radhi kwa hilo, kwa sababu lengo ni kuweza kuelimisha na pia mmetufunza namna na mmefunza watazamaji kwamba sote sisi tunavyojua kwamba iko siku moja tutatangulia na tujui nani ataenda kwanza amwache mwingine. Kwa ushujaa mlionao, mzidi kuwa na ushujaa, na bila shaka yule ambaye ana support ya kutoa azidi kuweza kutoa support. Nafikiri
kweli kabisa Rashid. Na tuomba radhi, we hope you forgiven some of the statements that came out. If they didn't come out right, that was not the intention at all. What we wanted to do was to have a conversation, end-to-end conversation, understand the issues you're going through, understand what can be done, and that's the reason why we had government to respond to you. So if that came out wrong, we deeply and sincerely apologize. Sarah, sijui kama pia wetu kupatia dakika moja tu, just to give recommendations going forward on what you'd like to see in terms of intervention.
Ningeongelelea huku kwa vijiji, walete hizo screening, waweze kufanya awareness. Juu kulingana na mali nimetoka Dandora, there's so much pollution. Hali ya hewa ni mbaya. Tunapata makansas mingi, watoto wanazaliwa wakiwa na cancers. Government iingilie kati, iangalie hiyo situation ya Dandora, ituondolee hiyo dumping site, ama ijue venye ita manufacture hiyo waste, ikuwe manufactured in something which will be useful in future. Ndio tupunguze hii maambukizi yenye inakuwa inaambukizanwa.
Naam, shukran sana, na kwa kweli tungependa kuzungumza na wengi, lakini pia muda umeweza kusonga. Labda pengine kutoka hivi sasa naweza kuambia kwamba tumeshukuru sana uwepo wenu kuja hapa studio na kuweza na maana sio rahisi watu kujitokeza. Kuna wengi wanapambana na saratani lakini wamejificha kwa sababu wanaogopa kujitokeza. Kwetu nyinyi mtasalia kuwa mashujaa na kweli mhitaji kupewa hongera sana. Mwendo sio mrefu, kwa vile jinsi ambavyo mlivyo tutasonga pamoja, tusonge pamoja na tuweze kushirikiana pamoja, kwa sababu hatujui kesho yote ikoje. Ni Mungu peke yake anayejua kesho yetu ikoje.
Kweli kabisa. And I think you all deserve yourselves a round of applause for being so strong enough to speak about this in person and also encourage everybody else who's out there. But I'd like to cross over now to the government studio where Sam and Christine are standing by for closing remarks. Sam?
All right. Thank you so much, Trevor and Rashid there. And we are closing matters here. Let me begin with you, Waziri, because so many issues have come up. I don't know if you have any comments about them. But also there's the stubborn question that many people, once there's a diagnosis, they want to travel to India because they can access treatment there. Sometimes it is cheaper. Sometimes it is accessible. But are there any conversations you would be having to ensure that, yes, the Constitution requires that every person has a right to access the highest quality of care? Are there conversations between Kenya and India?
Yes, Sam, thank you very much. People go to India because they want to look for better care. And sometimes it is out of lack of knowledge of what is available locally. For example, the studio where Lilian Muli is at the Kenyatta University Teaching and Referral Hospital, we have the CyberKnife. That is the second in Africa, one in Egypt, the other one here. While Kenyans are trooping to India, I have been informed that we have a list of 2,004 patients waiting to use the CyberKnife. And out of the 2,004, about 500 are foreigners. So for me, I want, as Kenyans, one, to cultivate a culture of being able to accept our own solutions, our homegrown solutions. Some allow me to speak about the bigger picture in terms of healthcare management. This is where we need universal health coverage. Under the 4 pillars, one, on the health commodity security, where we are saying we are leveraging on local manufacturers to be able to bring down the costs of items and equally ensure that we are able to replenish our stocks in a timely manner. And I think that question was posed to him. Is it possible that some of these drugs can be manufactured here? Yes, it is. Many years ago, ARVs were never manufactured in Kenya, but now we have a manufacturer doing ARVs in Kenya. So it is possible that some of these products, they can be manufactured locally. So we, under universal health coverage, we are ensuring that we beef up on our health commodity security. The other issue we are discussing under universal health coverage is human resource for health. Because it doesn't matter whether you have all this equipment, you have all these very good facilities. If you do not have human resource to practice and to put those products and equipments into use, then there is no service. Since we came into office, we operationalized the Kenya Health Human Resource Advisory Council. And it's supposed to look at the landscape of human resource for health, right from training. What numbers are going into training? How many are getting out of training? Are we managing our internship? Are we managing them when they are in service? And this specialty, are we able even to do inter-county transfers? Can we see where is it that we need more of oncologists? Where is it we need more of gynaes? So we are managing that front of human resource for health. But the other pillar of universal health coverage is digitization. And I think it is going to help us a great deal, especially like in this case where we are saying we cannot establish cancer centers in each and every county. But we are going to establish them under the regional centers, and we have put facilities under the hub and spoke model, where we have put facilities into a primary care network, that you could have one place that has the experts, has very high equipment, that can support facilities in a lower level. And a place like Tharaka Nithi, where Governor Muthomi is the governor, I have been there. He's already trying up this model of hub and smoke, where we were able, a senior medical officer was able to provide support to a clinical officer who's providing care at a lower level of service. And the last and the final pillar of this universal health coverage is health financing. And that is where rubber meets the road. And for us to be able to do all these things under the 4 pillars to ensure that we leave no one behind in terms of health access is where we came up with the 4 laws, the 4 acts. And once we are able to operationalize those 4 acts, then I am confident to say we are going to be able to take care of healthcare of Kenyans by ensuring that they suffer minimally, if at all. It should be that they should not suffer any financial loss. So I want to encourage Kenyans that the conversation that we are having right now is on regulations. Because for us to operationalize the law, we need regulations. So I'm inviting Kenyans to come and let us talk about these regulations. What is it that they want to see in those regulations so that we are able to ensure that we take care of Kenyans from end to end? We make sure that as Kenya, you go and access service, there are no limits. There are no exclusions. We are able to give you end-to-end. You see those patients who've talked about, yes, they are getting the care, yes. What about mental health? What about other issues? And we are saying we have developed a benefits package that takes care of a Kenyan across, integrated. So I want to call upon Kenyans, those who may not understand these acts, please seek information, and we are going to be available to provide information. This social health authority is going to be beneficial to all Kenyans. And I've said the greatest beneficiaries are the people with critical and chronic illness, because we have a fund in there of 46 billion. And out of the 46 billion, 42 billion is for cancer treatment. End-to-end management of a patient. Thank you.
Asante kwa maelezo hayo. Dr. Meli, katika usemi wako wa mwisho, pengine tungependa uzungumze kuhusu mambo ya dawa. Wale ambao wamezungumza, ambao wamepitia safari ya saratani, wanasema mara nyingi ukienda katika hospitali za umma, utamuona daktari, kisha utaambiwa kwamba dawa haipo, kanunue kwenye hospitali ya kibinafsi. Na hii bila shaka pia inachangia kuongeza ile gharama ya matibabu ya kansa. Je, upo mpango mahususi wa kusaidia katika kuhakikisha kwamba usambazaji wa dawa unakwenda sawa sawa?
Asante sana Christine, tunashukuru. Tuko na mpangilio mwafaka kutoka taasisi ambayo inahusika na matibabu ya saratani, National Cancer Institute. Na sasa hivi tunaongea na wahisani wote ambao wanahusika ili tuweze kutafuta njia ambayo tutahakikisha madawa yatapatikana katika hospitali zetu zote. Kwa sasa hivi kupitia mpangilio ambayo Wizara ya Afya imeweka pamoja na KEMSA, tunaweza kuhakikisha kuwa kuna madawa katika hospitali zetu 13. Na hospitali hizi ni za county. Zile regional centers 3 na zingine the former provincial hospitals wanapata madawa ambayo serikali kuu inanunua. Wakati mwingine kwa sababu ya reimbursements kutoka kwa hospitali zetu, kutoka NHIF, na NHIF waweze pia kulipa KEMSA, tunaweza pata madawa yanakosekana. Lakini vile waziri ameongea kuwa tukiweza kuhakikisha kuwa ile pila ya kwanza, bio manufacturing hapa Kenya, cost ya madawa itaenda chini. Na haya madawa yataweza kupatikana katika hospitali hizi zote. So tunawapatia Wakenya matumaini kuwa msiwe na wasiwasi. Wizara kupitia waziri wetu imeweka mikakati kuhakikisha kuwa haya madawa yatapatikana. Na vile tumeongea kuhusu madawa hata katika zahanati zetu, na pia kuna ile Facility Improvement Fund ambayo tunahakikisha kuwa ring fence pesa katika hospitali zetu kutoka level 2 dispensary. Hiyo pesa itapatikana kwa hospitali ambayo itakuwa inaangaliwa na ile committee ambayo wale wanakijiji wenyewe wameitengeneza, ili hiyo pesa itumike. Iwapo ni kununua madawa, watanunua, watauza, na pesa yao inabaki hapo. Itahakikisha kuwa madawa yatakuwa katika hospitali zetu kila wakati.
Asante.
And for you, Governor, as you wind up, probably as you reflect on the socio-economic impact, especially on the people of Tharaka Nithi, but what solution you'd be offering? Because we have sufficient problems, but you have to find the solutions. What would you be suggesting?
Three things. Three things. One, even as we sit here and have this conversation, the people at risk of suffering from this menace or the disease of cancer who don't watch TV and they don't listen to radio. That is why we need to have an approach that can be able to reach those out there that do not know where to go when they have that cancer. So it's a very big problem. And then like you've seen, the biggest issue, like it or hate it, it is around the cost. And it is usually not prudent to reinvent the wheel. When I started talking this evening, I said there are countries in the world who have already eliminated this issue of the threat of cancer. 90 or 95% of the people who get cancer don't die. What do? Research shows that those countries, all of them, the healthcare is normally in the hands of government, who pays the premiums from the taxpayers' money and ensure that we have comprehensive cover where nobody has to be asked for money when they go to hospital. So this issue of top-up of NHIF, this issue of go and get diagnosis and go get imaging, and you're telling a person who has come very desperate with nothing, you're telling them go get diagnosis, get an imaging, go get a CT scan, go send biopsy before they can actually be seen by a doctor. That is just condemning them to early grief. So as a country, from all the levels, the best, and I'm not saying the only solution, is the country must take up the comprehensive cover for all the Kenyans, whether it is by law, whether it is by coercion, whether it is by agreeing. Sometimes the pill is usually very bitter, but when it's taken, you get healed. We cannot solve that problem.
Do you see a solution from the Social Health Authority?
As long as the Social Health Authority does not have a strategy to bring in the funds from everybody. And when you say everybody, does not mean that it has to be everybody, at least a household. Then we will still be having that problem of exhausting funds. I like the fact that you've, in that social health insurance, visualized that it is possible for the funds to be exhausted at one point when you are treating a certain disease and therefore you need to move to the next level. What if the ones that have been set aside for chronic diseases, for those emergencies get exhausted? What happens? That is why we need to have a conversation that we should be able to invest more in that health sector than we invest in the sector. And let me give you a very good example as I finish. Dr. Meli has told us very clearly that to do a cancer center, which is comprehensive, costs around 600 million. Why would it be prudent to spend 600 million on 10 kilometers of a road to people who are dying of cancer? Why is it not possible to cut back that and even other sectors, including that housing that we are talking about here? Why are we very aggressive in collecting funds to do affordable housing, and we are not very aggressive in collecting funds to do cancer centers and be able to cover everybody also in Kenya? So our priorities are the ones that may be upside down. What is it that we are doing for Mwananchi they can't do for themselves? And what is it that we are doing for them they can do for themselves? And I don't want to go further than that because I think you understand where I'm going.
Asante Bwana Gavana. Ni masuala mazito hayo bila shaka ambayo yanahusu mazungumzo juu ya kansa. Dr. Primas Ochieng, wewe uko katika chuo ambapo mnatoa madaktari kupitia mafunzo. Wakenya wanataka matumaini. Je, tutapata madaktari wengi zaidi wa kutibu wagonjwa wa kansa?
Yes, asante sana. So kulingana na vile training ya madaktari saizi inaendelea, we are not just training from the university or from the education point of view. We are working closely with the Ministry of Health, with the NCI, and like most of the doctors we are training from the county are actually supported by the county. We are also, in this academic year, we have got 5 scholarships through the Ministry of Health where doctors, 3 of them will come from the country and they'll be fully sponsored by International Atomic Agency. Roche Pharmaceutical through the same ministry also are sponsoring another 3. So we are going to attract doctors and make it easier for them to just come for training, train and go. They don't have to pay fees like other students. So that will be one of the approaches that will make us train as many doctors as possible and attract them to train in oncology.
Asante.
All right. Dr. talk to us about your thoughts moving into the future, because yes, he says that we need to create awareness, but as all this is happening, there has to be successful outcomes because that's what everyone is looking at. What do you think would be the best path towards that direction?
Oh, thank you very much, Sam. My comments on this would be that we need a systemic approach. So we don't just isolate cancer and focus on cancer and forget about everything else. When we talk about social health insurance, it also depends on the economy, it depends on manufacturing, it depends on agriculture, it depends on all these things, education. So we need to look at this from, a a systems approach and make sure that every part of the system is up and running. Thank you.
Sam, allow me to say something. I think it will be wrong if we close this discussion without us having talked about it.
Okay.
Prevention is better than cure. And that is why, as a government, we are investing more in the primary health care to educate people. Now, for cervical cancer, we have a vaccine, HPV vaccine. And culturally, there are many people who are not giving consent for their girls to get the HPV vaccine. And that is the first point where we start with the prevention of cervical cancer. Currently, it is being administered to girls between the age of 9 and 15, that means they could either be in primary or in high school. But we seek consent from the parents. And many parents are refusing to give consent. Yet that is the beginning of prevention. So I want to appeal also to our mothers outside here, our parents outside here. We have enough doses of the HPV vaccine. It is being administered in school. Please give consent, because you do not know who is a candidate for cervical cancer. Let us ensure that they get this vaccine.
Is consent in writing or in person, physically?
We do it in writing. There are forms that are filled at the school.
Okay.
Yeah.
All right. So they have to do that during holidays, or how does that work?
Maybe during school
okay,
days.
During school. All
maybe on that, I would like to really support what the CSR said. That vaccine somehow in Kenya, the conversation went down. The countries which are succeeding, they have 100% coverage, but they're doing it differently. They're doing both boys and girls. Our neighbors here in Rwanda, they're giving it to boys and girls, so that conversation of we are trying to victimize our gender is an issue. So maybe it's an approach we need to take, and what's different?
Wow, I want to close, but Dr. Meli, what is it?
I would want to confirm to the country that through National Cancer Institute of Kenya, we are looking at these county cancer action plans. And for the 20 counties we've considered currently, we are ongoing. We are discussing extensively on this HPV vaccination because we have, a call to eliminate cervical cancer by 2030 by WHO. The first country that will eliminate is Australia. And they started this vaccination in the 90s. In Kenya, we started it 5 years ago. Currently, our statistics stands at less than 20% country coverage. And that is why we've taken deliberate efforts to discuss with every county. And I am happy to mention that Kirinyaga County are actually, from our statistics, leading in...
it's led by a woman.
Yeah, it's led by a woman.
And they understand. They understand.
So they have put a lot of strategies. And the strategy is using the existing structures under Ministry of Education. And if, Madam Waziri, we can have this as a discussion between Ministry of Health and Ministry of Education and just, have this public call to make sure that jointly we can administer this program. I am very certain that as we also administer vaccination, the other strategy is to screen all 70% of our women by 45 years of age and treat 90% of those with precancerous lesion and cancer. The three strategies must be administered jointly if we are to succeed in eliminating cervical cancer.
All right. I have to thank you all for making time for us. Waziri Nakhumicha Wafula of Ministry of Health, as well as Dr. Meli from the National Cancer Institute, Dr. Ocheng from the University of Nairobi, and Dr. Naftali from the Kenya Society of Hematology and Oncology, and of course, Governor of Tharaka Nithi, Muthomi Njuki, for making time for us. Thank you so much to have this conversation. And that brings us to the end of the big conversation. I don't know, Jeff, you want to say something?
After a 5-hour show, Sam, I don't think I want to say very much, but we can talk about this forever, can't we?
Yes.
Very heavy subject and very emotive.
True.
And it's not going to go away anytime soon. But at least we're having the conversation.
Ni jambo ambalo kama tulivyosema inagusa nyoyo, mifuko na hata imani
ya wale ambao wamekuwa na jamaa ambao labda wameathirika kwa njia moja au nyingine na saratani. Na ni matumaini yetu kwamba kama mtazamaji pia vile vile kabisa umepata kujifunza mawili matatu ya kuishi, na vile vile kabisa hamasisho tu ya jinsi ya kujilinda kutokana na ugonjwa huu, na vile vile kabisa wale ambao tayari wako nayo wasiwe ni wenye kuishi kwa unyanyapaa. In this case I mean stigma.
Unyanyapaa.
Unyanyapaa.
Very good.
Very right, and I don't have much more to add on to that. It's just looking at the quality of life for our cancer warriors, the quality of life that you're giving to even the caregivers, both at the professional level and even at home with those ones who are taking care of the cancer warriors.
Absolutely, and this show would not have been possible without the cancer warriors, without the caregivers, without the oncologists, without the government side, without all the stakeholders involved. Thanks so much for being a part of this show. To Vicky and Nimrod, Rashid and Trevor, Sam and Christine, and of course our guys in the field, Martin Monene Nyeri, Evans Asibe Nakuru, Crispin Otieno in Kisii, Laura Otieno in Kisumu, Ben Kiru in the CBD, Lillian Muli at the Kenyatta University Referral and Research, and of course the people behind the scenes that you never see.
The directors.
The cameramen, the sound engineers, the producers, the writers, and of course a director or two here. Thanks so much for being a part of The Big Conversation. You can keep tweeting the hashtag Big Conversation. Thanks so much, everybody. Good night. Good luck.
Good night.
God bless you all.
The State of Cancer, in partnership with the National Cancer Institute.